that, I'm going to hand it over to Christy Bartles, our Division Chief of Rheumatology, to introduce our special guest speakers.
Thank you, Lynn. So this morning, I'm incredibly excited to welcome two experts in dissemination and implementation science. And I am excited because this topic, again, intersects with all of us as we sort of think about implementation science, as I like to think about it as QI on steroids, which I know is a rheumatology-centric analogy here. But I am thrilled to introduce to you our new director of the Dissemination Implementation Launchpad and a member of the Division of Hematology, Oncology, and Palliative Care, Dr. Shellie Ellis. First, as our first presenter today, it is really my great pleasure to introduce Dr. Ellis, who is, again, an implementation scientist and director of the DNI Launchpad. She earned her PhD from the University of North Carolina in health policy and management and has background in actually anthropology, statistics, and many other areas of science that she brings a really keen lens to her work. Prior to joining UW SMPH this past summer, she was a tenured professor at the university, or tenured assistant professor or associate professor at the University of Kansas Medical Center. There, she worked in many different areas, including cancer research, blood pressure projects across many different uh, disease topics. But really, her focus has been translating evidence into clinical care that would help dispel health disparities, and in particularly, she was really focusing on rural populations. She is widely recognized for her implementation science research, where she has networked nationally. She's addressed many barriers to overcome clinical care barriers, including how to improve guideline concordant watchful waiting in prostate cancer, how to improve efficiency for somatic tumor testing for targeted cancer therapies, which she's done both in rural and urban settings, and how to reduce barriers to enrollment in participation in clinical trials. Beth Burnside, who helped with the recruitment to the ICTR group, really called out that, again, Dr. Ellis has had groundbreaking work in implementation science and cancer care delivery. This, combined with her interdisciplinary background, as I mentioned, in anthropology, statistics, health services research, makes her an exceptional addition to the ICTR leadership team, and we are incredibly thrilled to have her. Notably, that work in and clinical trial recruitment was really paradigm shifting in the field, and it was one of the first to think about behavioral approaches to use systematically improve implementation science principles for recruitment. She is now internationally cited for that work and is really lauded as a national priority and has had work celebrated by the NIH and the NCATS group. Further, under her leadership, she really grew the infrastructure at KU, and she plans to do the same and is really leading the charge here at UW. And we are thrilled for her continued growth of the DNI Launchpad and participation nationally to get us additionally networked. She was recruited here to be, again, the director of the DNI Launchpad, and we're really delighted to have her as a colleague here in the Department of Medicine. I also have the honor of introducing Dr. Maria Pinzon this morning, and I, again, am thrilled to introduce Dr. Pinzon, who's an implementation science and leader at the Wisconsin Alzheimer's Institute. She is an assistant professor here in geriatrics, and her research focuses on health services research and dementia care barriers and the health disparities in Latinx communities, again, with particular interest in looking at Alzheimer's disease in Latinx populations. Dr. Pinzon received her medical degree from Universidad Central de Venezuela and her master's degree at Rush University in Chicago, and she completed her preventive medicine residency here at UW in 2017. She has leadership positions with the American College of Preventive Medicine, and she uniquely is the president-elect of a medical organization of Latino advancement in Wisconsin, and vice chair of the Health Policy Professional Interest Group called iStart in the Alzheimer's group. Among many awards she has won, Young Physician of the Year Award by the National Hispanic Medical Society in 2020. She has won a Rising Star Award from the American College of Preventive Medicine and was named by Medscape as one of their 25 Rising Stars. Dr. Pinzon is currently funded has been funded in the past on a K99R00, which is a prestigious award from the National Institutes of Aging. And we're really, again, thrilled to hear both from a leadership perspective from the Launchpad and also an applied perspective from Dr. Pinzon. And without further ado, take it away. Thank you.
Wonderful. Thank you so much, Christy. That was a really lovely introduction, and I'm thrilled to be here and excited to be presenting with Dr. Pinzon this morning. Uh, Neither of us have any financial relationships to disclose, and we don't intend to discuss drugs or devices this morning. These are the learning objectives for the CME, which we hope you take advantage of. Today, we're going to talk a little bit about who we are, but also about dissemination and implementation science, and give you a little bit of many of you already know what dissemination and implementation science is, but we wanted to give you an idea for those who are newcomers to the field. And then I wanted to spend a little bit of time talking about the D&I Launchpad within ICTR and the resources that are available for all faculty to use. Then Dr. Mora will take over and tell you about the great research that she's been doing in the implementation science field. And we'd love to have opportunity to discuss and have conversation with all of you. So with that, I'm going to let Dr. Pinzon share a little bit about herself.
Thank you so much, Dr. Ellis, and thank you, Dr. Bartels, for that amazing introduction. So you already heard a little bit about me, and as was mentioned, I work a lot on improving access and dementia care, and I also love what Dr. Bartels mentioned of implementation science being QI on steroids. But then to center a little bit on what we're going to be talking about later, I want to present to you a problem, and then we're going to talk about that problem a little bit more later. Next. So when I started working on with implementation science, this was the problem. Every 20 minutes, an older adult fall and died due to that fall. So when we think about that's millions and millions of visits every year and potentially additional injuries that we were not counting even in this problem. Next. And there are solutions. I mean, that's one of the main things. The CDC has this compendium that's been publishing for over 20 years with multiple interventions that we know work for decreasing falls. But still, the problem is out there. This is a little bit more concerning when we think about the population of the United States is getting older, and there's a lot of changes in our demographics. We know by 2060, about 30%, 25 to 30% of the older adults will be of Hispanic or Latino descent. But when I started in this work, next slide, it turns out that there were no evidence-based fall prevention programs available in Spanish or regularly serving Hispanic and Latino individuals. So you might think about this, also identifying the problem in your own area. What are the things that we know work that improve the health of the people, but we are not doing it regularly or broadly to benefit everybody? All yours, Dr. Ellis.
Thank you. Yes, and so I appreciate that problem, and those are just the kinds of problems that I spend my career working on as well. Um, I Most of the work that I do is in cancer care delivery research. But as Dr. Bartels mentioned, I also get involved in some other projects that are outside of the cancer realm. Spent some time earlier this week in cancer grand rounds, and I talked a little bit about my research, but the cancer care delivery research that I've focused on have been really addressing two problems. One is recruitment to clinical trials. We know, and it's NCCN guideline recommended, that patients get care in clinical trials if possible, but there's a great disparity in that issue. Only about 8% of patients actually end up on trials nationally. So a lot of the work I've done has been taking an implementation science approach to that problem of recruitment and developing interventions to help different parts of the problem, most notably working with urologists. Another problem that I tried to tackle across the last decade of my career is precision oncology, revolution in cancer care treatments, and there's a lot of things changing every day for oncologists, particularly those in the community who are treating all comers, and trying to develop solutions to that problem, again, using an implementation science approach to that. So that's some of the work that I'm continuing here at UW, and I'm excited to do that, and would love to talk more about that. But now I want to switch and just talk a little bit about dissemination and implementation science. For those of you who are new, I think that dissemination and implementation science can really, this perspective can help you really think about the significance of your work, even if you're not doing it. Thinking about ways that the innovations that you are creating can be more relevant to the populations who you're going to put them into is very useful. So when we talk about dissemination and implementation, just to level set, we think about dissemination as the targeted distribution of information or intervention materials to a specific audience. And when we think about implementation, we're really thinking about the strategies that we might use to help people adopt and integrate evidence-based interventions within the setting that they're working in. And really the goal of D&I research is to increase our understanding of how to do this better, how to get evidence-based programs into practice. It's really focusing on the how. So what's all the fuss? Well, I like to say that a healthcare intervention that is 100% efficacious, but no one ever uses, is 0% effective. So, we spend a lot of money, we spend a lot of our time creating innovations, but if those don't get used, it really populations don't benefit from what we're doing. So we also know from research that there is this giant evidence to practice gap. There's a lot that we have discovered and that we know is the best thing to do, but we don't always do it. And there's some literature that suggests that it takes on average 17 years for research evidence to get into practice, for people to actually use it. And there's other research that suggests that only 14% of evidence ever really reaches a patient. And then there's other evidence that suggests that when we ask people who are providers and delivering care or delivering policy, if they actually use and consult the evidence base, and only 18% really go out and look for new evidence. So it's really clear that just publishing our research is not enough, that we actually need to be active and make those results actionable and help people actually adopt them in practice. So implementation science is, I keep saying it's a brand new field, but I've been saying that for about 20 years, and that's it's a maturing and a teenage field, I guess, at this point. So really the first coining of the term came about, at least in PubMed in 1993, but as you can see, the field has really grown. And now I would say that the field has solidified into an actual field of science. There are journals dedicated to implementation science. There are sections in clinical journals that are also for the purposes of talking about implementation within those clinical areas. There are numerous training opportunities in implementation science, and until recently, a lot of diversity supplements, particularly to increase the pipeline of implementation scientists themselves. And now at the NIH, almost every single institute and center has some kind of focus or interest in dissemination and implementation. There's a special NIH study section for dissemination and implementation, and special mechanisms at NIH that are more and more used and supportive of implementation science kinds of studies. Even other institutes are interested, or other organizations are interested in implementation science. Notably, PCORI and DoD are including implementation science in the work that they do. And I think even at institutions like NSF and ARPA-H, there's room and growing interest in how implementation science can be used or adopted to promote the agency's goals. So it's also important, even though implementation science is a relatively new field, it didn't just happen overnight. It's actually built on many other disciplines. So it's really pulling together economics, psychology, sociology, various fields and findings in those fields, the best evidence from those groups, to pull together how we can understand how to implement things in particularly healthcare settings. Although much work is done in community settings and in policy settings as well. But really leveraging what we already know and pulling that together. I also want to say that there are a lot of people and a lot of approaches under the umbrella of dissemination and implementation science. Some people like myself, we start with the quality gap. So very rigorously trying to understand what the gap is, the evidence to practice gap, and then applying methods to understand why that gap exists, why people are having a hard time doing the evidence-based behavior, and then taking, again, a very rigorous approach to match those determinants, we call them, the barriers and facilitators, to implementation strategies that will actually address those particular barriers. So not everything is an education problem or a training problem. There are often other kinds of barriers, and we make sure that we understand what's really getting in the way so that the solutions we propose have a better chance to more rapidly address that problem. And then we also test those strategies in numerous ways. There are other folks who come to D&I, as I call it, dissemination and implementation, we call it D&I, as innovation developers. So they have created an evidence-based practice and they have a lot of research to support their work. And so then their main interest is in spreading that work. And so we use all the same tools. We're interested in partnering with the interest holders, the people who are going to use those interventions, the end users, as we call them, and understanding, again, the barriers to that behavior and trying to figure out ways to bridge that and make it happen more quickly. So people sometimes come from different ends of the spectrum, but we're all using the same methods and spreading innovation. So D&I science is answering these questions. How do we decrease time to get research into practice? And how do we increase the success of dissemination, implementation, and sustainability? And how do we bridge this, what we know what's right to do and what we actually do in real world settings? So just to give you a couple of examples of how D&I has addressed quality of care problems. Some of our colleagues here at UW have been very successful. One example is the work of Andy Quanbeck and reducing heavy drinking from 38% to 22% using a D&I approach. Another example is the work of Majid Afshar, who has worked with the clinical implementation of AI-based screening for opioid use disorder and reduced 30-day readmissions using an implementation science approach. And another great example is the work of Dr. Christy Bartels, who has addressed high blood pressure in primary care clinics with some innovative audit and feedback approaches and had quite a significant impact, doubling timely follow-up to care, decreasing median time to care, and importantly, reducing the number of visits for high blood pressure at rheumatology visits. So now I want to tell you, now that hopefully I've convinced you that dissemination and implementation is a worthwhile thing to do and you're all interested in participating in this kind of research. So I want to tell you a little bit about what the Dissemination and Implementation Launchpad within ICTR can help you do. So for those of you who are not familiar with ICTR, it's an organization within the Institute that helps researchers grow their careers, increase your impact, and provides various kinds of training, funding, and services. There are a lot of consult services that you can take advantage of and help boost your research. So if you haven't checked out ICTR, you should, and see how they can help you with your research. And one of the important components of that, of course, is the Dissemination Implementation Launchpad. And we're there specifically to help assess barriers and accelerate the adoption of health-related innovations and increase impact. We have a D&I advisory board, an academic advisory council, and several members of the Department of Medicine are part of that. Of course, Dr. Pinzon, Dr. Bartles, but also others in the Department of Medicine who help guide. They do amazing work in dissemination and implementation, and they have volunteered to help guide what we do and bring their expertise to more people. We also have a staff of 2 scientists and other program staff who help run the programs. And these people are available to help talk you through the kinds of work that you're interested in doing. The things that we offer one-on-one consultations, national and local trainings, pilot funding, and then other kinds of support and networking and other tools and resources. And I'll walk you through a couple of those. So if you haven't had a consultation, I would highly encourage you to do it. People come to us with all kinds of questions at various stages of their research, and we recommend coming the sooner the better. People ask us about theories, models, and frameworks. That seems to be something that there are a lot of in dissemination and implementation science, but we can help you figure out which ones to use if that's something you're interested in doing. Planning for dissemination, co-design of studies. Some people need help with instrument selection or development, or particularly we get a lot of requests for support or help with qualitative methodologies, but also experimental study designs as well. So again, any question you have is okay with us. We'd have a consult form. You can sign up and schedule something with us at any time. We also offer training. We have an implementation science seminar series that happens the second Friday of every month at noon, and we would love to have you come. We bring in speakers from external experts who bring knowledge that we don't have necessarily, but we also have highlight the great work that's happening here at UW. And as I mentioned, we have a lot of work that's going on here and really groundbreaking implementation science. So we bring that to you. That course is offered for credits. So if you have trainees or staff who would like to expose to more implementation science, please have them come and join us. I teach that course in population health, so happy to get anyone hooked up and enrolled in that course. We also have a 12-credit certificate at UW in implementation science and community health outcomes. That's a fabulous program, and again, it's available for graduate students, professional students, but also what we call the capstone program, which is for people who are not seeking a terminal degree. So if you're writing a K award, this is a great opportunity to learn more about implementation science. That program is a 12-credit program, and there are requirements for translational and outcomes research courses, qualitative research, working with communities and other end users, and of course the seminar is part of that. It's a really great program, and Barb King in the School of Nursing directs it and can help folks find advisors in that program. The other thing that we're really nationally known for is our short course. And Felice Resnick, one of our scientists, directs that. It's really a nationally lauded program. People take it as part of their K Awards. Lots of folks from other implementation science centers come and visit. It's been going on for about 13 years, so it's got quite a reputation. We are really interested in taking a little bit deeper dive into some topics. This coming year, we're going to be exploring the intersections of implementation science and human factors engineering, 2 fields that are sort of parallel and intermingling, and UW is perfectly positioned to do this as they've been a leader in this particular area. But we also have other things coming up over the next 5 years, including the advanced clinical trial methodologies that we need in implementation science and other intersections of quality improvement and implementation science and other things as well. Another thing that the Launchpad has traditionally offered are funding mechanisms to help support folks at various points in their career and their trajectory of getting an evidence-based practice into the community. So there are designed for dissemination awards that help people who are developing interventions make sure that they're going to be used in the community when they're finished, when they're completed. We have an E2I award that helps focus on commercialization, and Dr. Pinzon will talk about her experience with that award. We also have had pipeline awards that once people have an evidence-based intervention and need some help in thinking about the spread of that intervention, that people can use those mechanisms to connect with the community. And then there are traditional research pilots that focus on D&I. And a mechanism that we've been involved in is the Learning Health System demonstration projects, which I think the call is actually open now for those, but those focus on the UW health system and using implementation science and many of the data infrastructure that the Learning Health System provides to do a project. So I think, in summary, I think the Launchpad has had great impact, and people who use the services of the project have nice things to say about it. I think you will be pleased if you have an interaction with the Launchpad. It's really high quality work. And I just want to say that there are a few new things on the horizon. As ICTR, the organization is funded by the NIH, and we're in a process of renewing that grant funding, which is significant to the university. And as we're doing that, we're thinking about new programs that we can offer as well. And so we recently did a survey and a listening tour and are gathering ideas about what people need. And if you have ideas that could help us think through what we might need to do in the next era of the D&I Launchpad, I'd be happy to hear those. People have already told us some really important things about connecting with other implementation scientists. And we just recently did a survey. Faculty were well represented, but we're still happy to take ideas if you didn't get a chance to participate in the survey. And we're learning that really we're not beginners anymore. A lot of the faculty here, as evidenced by our Academic Advisory Council, are really expert or experienced dissemination and implementation scientists. And so we're thinking about new things that we can offer that meet the needs of those folks, as well as keep bringing people and beginners into the area. So again, we're thinking about some new directions. One of the things will be addressing research bottlenecks within the institution. So applying an implementation science approach to research bottlenecks to hopefully address them. And so if there are things that you'd like to put in the chat that you'd like us to consider addressing, we'd be happy to hear that. But other things we'll be doing, perhaps creating some mentee cohorts and hopefully trying to get together people who are interested in similar things more purposefully. So if you want to learn more, here's the contact information. We hope that you'll visit us. And now I'm going to turn it over to Dr. Mora Pinzon to tell us a little bit more about how she's approached this in her work.
Thank you so much. And I'll start by saying that all of these that I have learned through the Launchpad and different consultations and different projects, and even I have got some of the small grants and pipeline grants. So that's a huge resource, and don't think that you need to learn everything on your own. So one of the first things in applying dissemination and implementation principles is thinking about the frameworks. And the frameworks, think about them as a checklist. They tell you what are the things that you're looking for, but also what are the things that affect those outcomes. So it's an easy way to not getting drowned on, okay, but what should I measure? There's so many things that could be affected, but really emphasize the important things. Next slide. And there are multiple types of frameworks. So, but I will classify them in three big groups. The frameworks that are for describing or guiding the processes for adaptations and implementation, how to translate something for practice, for research into practice. Those are process models. They are the frameworks to understanding what are the factors that are affecting your outcomes or your implementation, and they are the evaluation frameworks. This could also be further detailed. There are some frameworks that are more emphasis on dissemination. When we already know that things work, how do we get them implemented more broadly? And there are some other ones like they are a little bit more, okay, I still don't know how this works exactly. How can I make it work? Next slide. One of the most common frameworks that I use all the time is the REAIN framework. And what I like about this one is that it's very simple and looks at the implementation outcomes. When having conversations with people, a lot when we think about outcomes, I can see that many of us think about health outcomes. Does this decrease hospitalization? Does this improve the hemoglobin A1C? Does this change my survival time? But thinking about how does an intervention or a program goes to the real world is about important to think who is getting the program, and that's reach. How do I know that the program is getting to the people that actually need it? Effectiveness, this is very related to the outcomes, is that if when I apply my program in the real world, does it still work? Do we still have the same success? Adoption, how do I develop organizational support to deliver my intervention? So basically, if I offer this to people, will they take it up? Or there will be problems or concerns about this is too complex, this is too expensive, we already have a different project. How likely is that you are solving a problem and not adding something that people do not want? Implementation, that relates to, is my intervention or program being delivered as intended? And we know that things happen, and there's sometimes that things cannot be done the same way every time due to emergencies and other factors. But if the program is relying on always doing something in certain order, how likely is that that's always going to happen? And finally, maintenance. The way that I usually apply this one is that we know, for example, that New Year resolutions, we always start strong, but then things start falling off the cracks. This is the same maintenance. Can we keep it up? After the initial period, after the initial excitement, can we actually keep doing the things that we were supposed to be doing? And that's an example of one of the frameworks. Next slide. But this framework has been revised, and now there's a second version that's called the Practical Implementation Sustainability Model, or PRISM. It still includes the same factors, but also is now looking at all of the context, all of the factors that affect those 5 outcomes that I mentioned. And I would like to just call your attention to one little part in the middle of the graph. This is looking a lot into health systems, and that's why one of the things that they're looking for is what is the perspective of patients, families, caregivers, and the individuals. And this includes staff and other members. Because at the end of the day, it's not only does this work, but also do people like it? And that's one of the things that the frameworks will help you to look at. What are the things that affects certain of the outcomes in a way that is manageable for the research process and for your work? Next slide. But also at the same time, there's frameworks that are a lot more expensive. For example, this is the Consolidated Framework for Implementation Research, or CIFR. This is called a meta framework. It really includes domains. It has, like last time I checked, it has 157 domains for multiple frameworks. And it really can be a very comprehensive way to look at a problem. You will see that they look, for example, the outer setting, the darker blue, which is where is this happening? City, what is the policies that are in place? What are the regulations that are in place that are affecting how I do an intervention or no? The inner setting, that's the lighter blue, which is looking at the organizational level. So it's not the same to apply an intervention, let's say in a private practice, than in a large academic hospital. There's different resources, there's different materials, there's different patterns of work. But also it's not only about the institution organization, but also the people that work there, the individuals. What are the training that they have? What are the resources that they have? How they communicate with each other? What is the staffing rate? All of those things affect how we might implement that intervention. And notice that I haven't even talked about intervention itself. But that's also in the green aspect, the thing. This is what I'm applying. And sometimes it gets confusing because the thing might be multiple little things bundled in a package. But that's one of the things that is important as we looked into implementation science. What's the thing? What's the thing that I'm looking to implement? Or what are the things that I can do to make it easier or harder to implement it? And also the processes, which is the last area in the upper part of the graph, which is basically all of the things that are happening, the pain systems, structure, how do we make this happen? Again, all of the frameworks are useful, but not all of the frameworks will be the framework that you need. And that's one of the things that when there's too many things to pick up, it's really important to think, what's my goal and how do I pick the right one for me? Maybe you're looking just one little part of it, and that's fine. Next slide. And I'll show you a little bit now how I apply that in a couple projects. So remember the problem that I gave you that in 2010, when this started, there were a lot of falls, and a lot of programs, but none of them were for Spanish or Latino individuals. Next slide. And this is where one of the programs came along. Some of you have heard about Stepping On. This is an evidence-based fall prevention program. In a randomized clinical trial, it had shown that the 31% reduction of falls, developed in Australia and brought and adapted to the US by Dr. Jane Mahoney, which is an emeritus faculty in our department. And it's been available since 2008. Last year, this program was available in 26 states, offered almost 3,000 times, and serving 31,000 individuals. And that's a lot. But then again, 2010, there was no Spanish version, but there was interest from some community organizations here in Wisconsin on how to make it happen. How can we make this available for Latinos? Because there's a lot of things out there that we know work, but might not be comprehensive, or just like up to the individual doing it to adapt it. And there's questions about, does it still work when we just let it to the facilitators or the groups to adapt as they see fit? Next slide. So part of this process ended up in being Pisando Fuerte, which is the linguistically and culturally appropriate version of Stepping On. Next slide. This process started with an adaptation process with consulting the people that was actually gonna use the program and consulting the experts that have worked with the Hispanic Latino older adults for several years. Throughout different meetings, they revise each of the aspects of the program, identifying what are the things that we can change, what are the things that are concerning, what are the things that need to stay the same, because these are what make the program work. And I think that that's one of the things that is very important when we think about adaptation of programs. Next slide. What makes the program work? That's what we call a key element. Think about it this way. If I say, for this program to work, you need 5 nurses, 2 social workers, and an online platform. There's a lot of bells and whistles to make the program attractive or easy to use. But what's the key that makes that the patient will help or receive help in the program? Is it the social worker? Is it the online platform? For our project, we already have some work done by Stepping On, where they did a Delphi consensus in order to identify what are the key elements, what are the things that should not change, because these are the ones that result in the improvement of health outcomes. And those were the things that as the sessions went along, the collaboration sessions, they were the discussion of, okay, what can we change? What need to be adapted? Understanding that might be affecting the final product, or what are the things that we need to keep absolutely the same way in order to make it work. Next slide. And some of the changes, you might think like, wow, but that seems like a huge change. For example, who can deliver the program? Stepping On, one of the requirements to be a facilitator for Stepping On is that you need to have a background in an allied health professional. So either RN, PT, OT, social worker, somebody that has healthcare experience. Keep in mind then for Pisando Fuerte, Spanish version, Latino version, less than 6% of the healthcare staff workforce is of Hispanic or Latino descent, less than 6%. That already limits who could be your facilitator in the program. So part of the discussions were, can we expand this to include other people that we know that that we have easier access in the Latino community? This includes community health workers, health educators, or other individuals like promotoras or other assistants. The answer was yes, but. Yes, we can expand it, but it means that we really need to evaluate what is in the training program to ensure that they will still get all of the tools and knowledge that they need to apply the program. And I'll talk a little bit about how we solve a little of those problems later. But this was key. This is one of the key aspects. We know that we needed a facilitator, and we know that we needed a facilitator that could connect with the individuals. That changes depending on who the population is. Next slide. Other of the things that we changed is actually the topics. Although falls have specific risk factors like medication, exercise, home hazards, and across this process, it was noticed that Latinos needed some additional information about things that are not common knowledge. One of those themes that we added, how to talk to your doctor. Something that it was shown by the experts that many Latino individuals will never have particularly older adults, will never feel comfortable asking their doctor, well, why do I have this medication? So that's one of the things that was included in order to make sure that all of the other instructions will be useful and they understand why we teach them the things that we were teaching them. Next slide. And one of the other main changes is the structure. So for stepping on 7 sessions, each one of 2 hours, once a week, people receive guest experts. So there's coming pharmacists, ophthalmologists, or optometrists, safety experts to do a 30-minute session with the older adults to facilitate the learning process. And all of the materials were at an 8th grade reading level. For Latinos, we needed to do some adaptations. Latinos, we tend to talk more. So we needed more time. So that in one of the first things, increasing the time of the sessions. Again, remember, less than 6% of the healthcare workforce is Latino descent or speak Spanish. So we couldn't rely on having guest experts on every session. So new videos were developed in order to facilitate the learning process without the use of interpreters. But additionally, we added, how do you use an interpreter? How do you modify the session? Because having an interpreter will add time to your session. And finally, 3rd grade reading level for the handouts. It's very hard. The manual is at 8th grade reading level, so we did it as simple as possible for facilitators. But all of the handouts, materials that the participants will receive had a lot of images, shorter words, shorter sentences to make sure that it was easy to understand and that they could bring it home and discuss with family members. One of the things also was having everything in English and Spanish. Many of the older adults live in multi-generational households where the younger generations might understand spoken Spanish but do not read it. So having the materials with the Spanish side on one side and the English on the other help to bridge that connection with the families. Next slide. And all of this was evaluated using the REAIM outcomes, which for us, this is how we define them. Reach, the number of individuals screened or enrolled. The effectiveness, did it work in reducing falls? The adoption, did the organizations wanted to do it again? And the implementation, were we able to deliver the program as intended? Next slide. So let's see if it worked. Next. Let's start with reach. So this is one of the studies that we did. We have done a few. But then in this one, there were 29 people screened and enrolled. Of those, 82% completed the baseline assessment and 87% completed the program. But those numbers without context is like, okay, is that good? Is that bad? So here's I'm giving you the results of another study for Stepping On, where they have very similar reach. About 80%, usually 80% of the people that signs into the program completes the first baseline assessment, and 82% of them complete the program. So just based on these numbers, okay, we are reaching the population that we want at the same levels that the other groups. And think about in clinical trials, this is where we might think that we sign up 1,000 people, where only 50 were enrolled at the end. Very similar concepts in this case. What are the barriers? What is happening that the people do not keep going with the program? Next slide. Did the program work? So very small sample size. We did not have the power. So, but in general, what we saw was that there was a decrease in the numbers for of falls per person over 6 months. It was a 68% decrease, but again, this number is not statistically significant because it's a very small sample size. But based on all of the other results and all of the other factors that we looked at, we saw that the people did the things that they were supposed to be doing. If we had a larger study, we probably would have shown a statistical significance. Regarding the adoption, the next slide. We know that there was a lot of good interest from the local sites. We have received inquiries from the national level that they will be interested in doing the program. And most of the people that have been interested or maybe not sign up to do the program is because of barriers or limitations that are external. It's not that they don't want the program. It's like things, for example, well, but we do not have the funding, or right now we're in a transition period. We'll reach out later. Because at the end of the day, it's one of the things that doing a program is just more than say, oh yes, let's we do it. It requires a lot of planning. And that's one of the things that we were hearing, but that people like it and organizations like it. Next slide. Now, talking about implementation of the program. So fidelity of delivery. Is the program being delivered as you intended? We established an 80% requirement so that 80% of the time the program should be completing all of the checkboxes. The first time we run it, you see is the red bars, just a couple of the areas had above that 80%. And remember that we changed the type of instruction that could be in the program. So after doing a reevaluation of this, it was, okay, what were the issues? Many of the facilitators needed additional training on certain aspects in order to be able to deliver the program correctly. We did a few changes in the training program. They were more about more practice, more emphasis in certain educational aspects. And then after running it again, we saw all of the values, 83, 92, 93% of fidelity. That's again showing that it might require a couple tries in order to get the right combination of factors. Next slide. But also, that's at the organizational level. And the individual level. Did the participants did the things that we taught them? That's why we're looking at fidelity of enactment. Did the participants actually took in what they learned? This is the false behavioral risk scale, which basically measures the number of protective behaviors that somebody applies, like using assisted devices, avoiding risky situations, using slippery slopes when they shouldn't. And we saw that after the program, most people did understood those risk factors and the risk behaviors and started doing more protective factors. And that's one of the things that this was statistically significant. We saw, even though it was a small sample, most people in the program actually took in and learned what was taught, and I started to apply it on the daily life. Next. And this is also part of the maintenance. What did we see? Remember, New Year resolution. Did people keep it up after the program? And we saw that yes. After 6 months, they were still, 60% of them were still doing the exercises. Next. 67% of them have eliminated hazards at home, which that's a harder one. This removes like putting handrails, removing rocks, and doing other things that require a little more time, but 67% apply it. Next. And 90% of them report the changes walking and standing. And that's huge. I think this relates to, again, those behavioral protections. Are they looking where they're walking? Are they taking their time? Are they making sure that they use the handrails? They keep up those changes. At the organizational level, we hear the same thing. Many programs, once they do it, once they want to keep doing it, they might have difficulties due to funding and other factors, but it's not that they don't like the program. Next. And again, all of this came by looking at the different frameworks. And this is the screenshot of the Dissemination Launchpad, sharing a few of the links. And there's a lot of tools out there. You can play with a lot of different tools to see, okay, this is what I want to measure, or these are the things that I care about. And it might help you to match and find the right framework for you. Another example, next slide. And you can go a couple. As some of you heard, I'm also part of the Wisconsin Alzheimer's Institute, and we have a network of clinics around the state. This network of clinics, they are not just UW Health Clinic. These are 30 to 40 clinics every year that belong to 21 different health systems. Next slide. And we wanted to apply the program to measure the quality of care that they were providing. So one of the things that we did was looking, okay, what are the things that we know work to facilitate this implementation of a new process? In this case was collection of quality data. And this is one of the seminal papers in the field, I think, that's called the ERIC project, which basically does a compilation of these are the things that we know have worked or have been implemented to facilitate changes in processes or implementation of new programs. And out of 73 different strategies, we pick 4. Next slide. Which were centralized technical assistants. So we defined one person that could answer all of the questions. We changed the type of data collection materials that we were developing, develop additional education materials. So when a new staff was changed or something, they could refer to those and find the answers they need without needing a consultation. But also we make sure that we conduct educational meetings on a regular basis to keep their knowledge fresh. And that's just an example of a different way to use the framework, so the different tools in implementation science. Next. In summary, considering dissemination implementation can improve your research at any point. If we think about who is going to use this program later at the early stages, we can really help to make it more impactful and more useful from the get-go. The frameworks could help you to plan, to understand the way that the plan is going to go, and evaluate the implementation full. And reach is an importance and effectiveness. As Dr. Ellis mentioned, something could be 100% efficacious, but if nobody uses it, it's 0% effective. So this is one of the things that we hope that we help today to learn a little bit more. Dr. Ellis, all yours.
Yeah, well, I would love to entertain questions. I think there are many things that are being developed and designed in the Department of Medicine, and we would love to engage with folks to help understand how we can implement and how you can implement those things in real world settings. So happy to entertain questions and invite you all to please use the resources of the D&I Launchpad.
So again, we'll welcome questions in the Q&A button on the chat feature here. So not the chat, but using the Q&A button below. And it looks like Dr. Schnapp has a question, but I'm going to actually take a little bit of prerogative. It's okay. First of all, Dr. Pinzon, Pisando Fuerte means walking strong, and I think you are walking so strong, and thank you so much. You were really inspiring giving us that demonstration. So first of all, thank you for that. I've got one question for Dr. Ellis, but I'll actually let Dr. Ellis. My question for you is a simple one. Is this relevant for folks who are early, like trainees? Could fellows or residents come to talk with the folks at the Launchpad and could mid-career folks come talk to you at the Launchpad? And B, where would you advise people to start?
Yeah, everyone is welcome, no matter the career stage.
Uh-oh.
I think you froze. Dr. Schnapp, do you have a question for Dr. Pinzon or?
Yes.
Go ahead.
Excellent. So thank you, Maria. A really wonderful overview. Always fun to hear you talk. And my question is, what are your thoughts on incorporating the economics of interventions? Because it does seem that one piece that could really enhance the argument for the implementation of programs is the financial impact, because all of these programs, when you're talking like in your fall program, it costs money to develop the materials, et cetera, and to have the staff. And so I think, how do you incorporate the benefit, the financial benefit, because that's what drives a lot of decisions these days, into the equation to help strengthen the argument for developing those programs for implementation?
That's a great question. And I think this is one of the key aspects and the earlier designs on involving who is part of the program. Because, for example, if we are relying on insurance or Medicare to cover certain services, what are the things that need to be part of the program or the documentation in order to ensure that if we apply this new process, a new quality improvement, it will be paid by our current revenue sources? Or in the case that if it's an external revenue source, for example, will patients actually pay for this new program or this new medication or whatever it is? The financial aspects is a make it or break it in our current system. So thinking about what is the actual cost of the intervention, will we actually saving money, or if we are not, is it something that still can be reimbursed under our current methods? That's a key on the early stages. And I think we many times we think like, oh no, I need to see first if it works. If it works but nobody pays for it, still we cannot do it.
Right. But building into that what are the cost savings? What is the savings of avoiding falls, X percentage of falls for us in our system. And you've got an appointment in population health. There's a lot of great
Anonymous.
people there working in that area. So I'd love to see some more collaborations in that area.
And Lynn, many of us have done this. Our Quick Connect program costs $15 per quit. We've published that. So again, I think there's a lot of great evidence for this. And Shellie probably has resources and tools they can get you from the Launchpad to do those things, even back of the envelope, which is great. I see a question here from Dr. Carlson. It says, do you see a trend in RTTs integrating D&I principles into their protocols? Or are they still leaving implementation scientists to do that post-trial? Dr. Ellis, I'm going to pose that one to you.
Yeah, that's a great question. So one of our colleagues has coined this term, the hybrid effectiveness trials, and there are even multiple types of hybrid effectiveness trials. And the whole point of these approaches to dissemination and implementation research is to really build in understanding implementation of an intervention while you're testing its effectiveness. So people can put as aim one of their study to test the effectiveness of their intervention, but other aims in the grant structure would actually look at the implementation. So really understanding as you're rolling this intervention out and testing its effectiveness, what are some of the barriers that the end users encounter, and how do you think about overcoming those, and what strategies have people who have been successful in doing it used to make that happen? And so that's a great structure for grants. Study sections really like type 1 hybrid effectiveness, implementation effectiveness studies. And it's something they really, understand, and it fits well with the NIH structure of developing studies. So we can help you think about that. If you already have an evidence-based intervention, we can do something fancy like a type 3 implementation effectiveness study. And that's really studying comparing different implementation strategies themselves. So those are really fun to design. So come and talk to us about those.
Another fantastic question in the chat, Dr. Barzy asking the question about recognizing that influencing change in health systems is hard. How do we engage leaders early to get buy-in to improve the chances that the change will be supported?
Yeah, that's a great question. And it's really super to think about that early on. We often don't think about who's going to actually do the implementation. So we sometimes think, the societal perspective in terms of cost, for example, but there are things like implementation costs for the organizations who adopt a strategy. And so thinking very carefully about who those people are and how you might engage them. So we often may do acceptability testing with a group of healthcare administrators. So often in my studies, we include healthcare administrators as important folks to understand what they think about these interventions and what barriers they see to implementing them. So certainly asking them, including them formally in your research is a good idea, but certainly connecting with them early and thinking about, the same strategies you might think about to connect with maybe physicians or other providers who are developing your intervention. How might you connect with the groups that represent those healthcare administrators? So we can do the same kinds of strategies for them.
Fantastic. Well, we are right at the top of the hour. I want to thank you both for a really inspiring and practical talk this morning, and also just welcome people to reach out to the DNI team that you. I really appreciate you. Thank you so much for leading us today.
Thank you.